Welcome to our webinar today on the real-time release of labs to patients and what this means to your practice. We're lucky to have several speakers with us today, including those names that you see there. And thank you very much for joining us today. This meeting is being recorded. And so the presentation part will be displayed on the AMA website afterwards. We do record for our records purposes the rest of the meeting, but the comments and Q&A time will not be posted. But please do know that by participating in the live Q&A, we will be able to see your name as signed in from Zoom. Okay, next slide, please. We would like to recognize that we're webcasting from and to many different parts of Alberta today, and the province of Alberta is located on Treaty 6, 7, and 8 territory, and it is a traditional meeting ground and home for many Indigenous peoples. In terms of disclosure, this program has not received any financial or in-kind support. For our presenter disclosures, we all have employment relationships with various places. However, none of us have received any funding for work related to what you are hearing about today from any industry party. And at this point, I'll pass it over to Dr. Michelle Warren for the AMA board.
So good afternoon. I'm pleased to be here today on behalf of the AMA board to welcome you to today's talk. We know that continuity of information enabled by technology can result in better continuity of care and quality of care. We know that engaging patients in their care, allowing them to help manage and be partners in the course of their care, improves quality and their satisfaction. With the availability of all but the most sensitive or complex lab results to Albertans in the next few months through My Health Records, we're witnessing a nexus of care continuity and patient engagement. It will be a big change for patients. It will cause some anxiety and some empowerment as well. It's going to be a big change for physicians and practices, and that's why we're here today. This is a project that's been in the works for a long time and has been supported by the AMA since its beginning stages. Because the future is here and we must change to meet it. This is what patients want and expect to see, and I am confident that we can meet the challenge of helping them through this transition. I will now turn it over to Heidi Fell, and thank you.
So I think at this point, I'm actually going to turn it over to Dr. Alan Osford. Dr. Osford is a primary care physician in the Edmonton area who has been a longtime user of patient portals with lab. So Alan, over to you.
Thanks, Heidi. Welcome, everybody. Thanks for attending today. Just to give you some background information on what we're doing, recognize that any Albertan over 14 years of age who's registered with My Health Records in February 1st is going to be able to see approximately 95% of their lab results. And in July 1st, they'll see the remaining results, including things like microbiology, pathology, and genetics. Things that are a little more sensitive are going to be delayed a little bit. And we talk about these in terms of phase 1 and phase 2. We're talking mainly today about phase 1 of the release, and that's the information we're trying to give you. A key part of that is the results will be available in near real time. And what that means is as soon as it's available in the lab repository, it's going to be available for the patients using the portal to be able to see. Also keep in mind that any new user that's registered will be able to see 18 months of their lab data going back 18 months from today, back 18 months. These changes that we're talking about were approved by the Health Information Executive Committee, which has representatives from many different organizations. They're listed there everywhere from Alberta Health all the way to the public. And so a lot of thought was put into the decisions being made. And if there's any questions that way, we can always review that later on, sort of thing. So the session overview basically is we want to make sure providers are aware of the lab posting changes that are coming in phase 1. We want to talk about important concepts that phase 1 has. We're especially wanting to make sure that you can hear from providers who have been using these types of tools and their experiences, because there's a lot of thought out there about what may or may not happen versus what actually does happen. And of course, we want to answer additional questions you may have about these changes. In terms of objectives, we want to consider the possible impacts of real-time lab release for patients and the implications of pretest counseling. You're going to probably hear the importance of pretest counseling from every one of us presenting today. It's very important in light of having a patient portal. And we're also going to talk about, we want to make sure that we review the possible impacts of patient access to labs on physicians, on you, on clinics, and on hospital workflows. So patient portals in Alberta. What are they? How many are out there? What's going on with them? There's really two main classifications. There's a provincial set and there's a local set. Within the provincial set, basically patients access through My Health Records. And within My Health Records, there are 3 different patient portals available. There's My Personal Records, which is the Alberta Health tool. There's My AHS Connect, which is part of Alberta Health Services Connect Care Clinical Information System. And there's also a rudimentary lookup tool for patients that need to look up their kids' results in terms of COVID-19. On the other side, there is a variety of local patient portals available. And so a number of different physician EMRs in this province have patient portals with varying levels of functionality. And as well, patients can make use of certain tools. There are actually apps they can download to have their own local patient health record sort of thing where they're putting information on. For the purposes of today, we are mainly talking about the first 2, the one in blue and the one in green. We've color coded them just to make sure that it's easy to follow. We picked the color of Alberta Health is blue and Alberta Health Services is green. So we picked those 2 colors. So as we're going through this, it'll help you to keep in mind which one we're talking about as we go through it. So in releasing results to patients, there are many ways of doing this. I do a lot of international IT consulting work, and we've actually done a world scan on the different ways. And this is just a list of all the different ways that results can be released. They can be released anywhere from in real time, which means immediately released, to being not released at all or released only when explicitly triggered. We're only going to be talking about 2 of those types of things in our presentations that will be covered in a few minutes here. Important concepts. So important concept number 1, there is a difference between real-time and delayed posting. Remember, we said that patients are going to be receiving results as soon as they're available. We know that some providers are receiving batch feeds in terms of results. And it doesn't matter whether it's paper, fax, or electronic, they're getting it as a batch maybe once a day or maybe twice a day. So it is possible that your patient may see a result before you've received it in those scenarios. What's important to recognize with that is if a patient contacts you about a result and you haven't received it, it will always be in Netcare. There's nothing a patient will receive that won't be in Netcare. So as long as you have access to Netcare, you can go there, see the results, and discuss it with the patients. When it comes to the difference between the 2 main tools we're talking about, the My Personal Records, all results will be released in real time. When it comes to My AHS Connect, part of Connect Care, most results are released in real time, but sensitive results, such as pathology reports, diagnostic imaging reports, genetics testing, are released after 5 days. So there's a 5-day delay before the patient sees it, but you'll be able to see it as soon as it's released. Once you see it, if it's within that 5-day time, you have the option of clicking a release button, which means the patient can see it sooner than 5 days should you choose. Another important concept is the idea of passive versus active posting, and it has to do with how patients know whether their results are available or not. So in My Personal Records, the patient has to pull that information. It means they have to go to the website, log in, and then they can see their results. In My AHS Connect, a notification is pushed to patients as soon as there's any new information available in their patient portal, and that can be via email notifications or with mobile apps. Another important concept is the ability to attach a message to a result as you're viewing it. So as a provider, when a result pops into your in-basket, in My Personal Health Records, there is no way for a note you would post on there to be seen by the patients. In My AHS Connect, the provider can actually attach a message as they're looking at it, and when the patient views it, they will see your attached message. So you may have a comment to say, don't worry that your MCV is 1 point over normal in your CBC. This is of no consequence, and they would see that. In fact, there's a lot of other functionality in My AHS Connect as well that's sort of different. And rather than go through that, because it's out of scope for this talk, we did provide you with a couple of links. So if you want to actually see some of the other functionality, those links are there. The detailed one is about 6 pages long. So another important concept is the context of what's going on. So remember that patients can see this regardless of who ordered it. So a patient may contact you as their provider to talk about a test that you didn't order or that wasn't even CC'd to you. And the sort of knee-jerk reaction to that is to say, well, you know, I didn't order it, go talk to the guy that ordered it, they'll go over it with you. But there's some sort of situations to keep in mind, and there's professionalism involved in what we do with this. So if it's a critical result, don't rely on the fact that the patient is going to be able to talk to the specialist immediately. You may need to deal with that and help them deal with that. If it's a result where there's a lot of detailed follow-up required, make sure that you're checking with the patient to make sure that they get that follow-up with the specialist. And if you have no idea where the test was even ordered, you may need to talk to the patient, get a little more context about why it was ordered and helping your discussion with them. Another important concept is sometimes appropriately a provider may order a test and put you as the primary ordering person or CC you. And there are a few episodes that we've all experienced where inappropriately you're CC'd or inappropriately somebody actually puts you as the ordering provider. That's no different than what we've lived with for many years prior to having patient portals. So it's important that you understand that these kinds of things are going to occur and have an approach in terms of what you're going to do with them. So let's talk a little bit about my personal experience. You know, I and my patients have been using Alberta Health AHS Connect for many, many years. Some of my patients, and you're going to hear from other people, that a lot of their patients are using more than one portal as well. So remember that patients can use more than one portal. But in general, the number of inquiries from patients that I received was far less than I expected. And this actually fits with the literature that's out there. Everybody worries that as soon as you turn this on, you're going to get inundated and flooded with people talking to you or asking you about every single result. The reality is that doesn't happen. Even in British Columbia, when they started mailing out results to all the patients, which was many, many years ago, they did not experience that. So it's not overwhelming in my experience. A small number of patients, however, may need to be coached on appropriate communication. We all know who those patients may be in our practice. We know them and we love them, but we know that they're sometimes, you know, a little more anxious or whatever. And so in my experience, out of 1,200 patients, I've had one patient where I had to have that conversation and say, you know, don't use this as a chat and don't keep, you know, calling me on every single result. Here's what's appropriate. Here's what's not appropriate. Another important thing that we've learned is do not have patients rely on asynchronous messaging for urgent scenarios. So if somebody is seeing a result or having a symptom related to that result that's urgent, they shouldn't be messaging you and assuming you're going to message them back immediately. And in fact, on my AHS Connect, plastered all over the screen where they can post a message to you, it says this is not for urgent issues. Please allow at least 3 business days before you may get a reply. If this is urgent, please phone or please use a synchronous form of communication. So the other part of personal experiences is a whole idea about pretest counseling, and you're going to hear about pretest counseling from every one of the people presenting, I think, today, because it is so important. Talking with your patients in advance of ordering tests where there may be sensitive results or where there may be an issue in terms of interpretation, or maybe they've had a long-term slightly abnormal result, but now that they're on the portal, the first time they see it, it's going to be a shock to them. Having that discussion with them in advance is very, very important. And recognize too that within the systems, patients also have a button they can click off the result that'll take them to myhealth.alberta.ca and explain what the test is, which is both a good and a bad thing, because often the word cancer is used in some of those results, even if an ALT is 51 instead of 50. So we need to make sure we do that pretest counseling. Educate your patients on how you and your clinic review and act on results. If they understand your system and the way it works, they'll better understand what a typical delay may be before you get a hold of them and what goes on that way. We all probably do things a little differently, so making sure they understand how you do things is very important. But overall, I think the most important part of this is that patients greatly appreciate seeing results. And they love the ability to discuss them with you without necessarily having to do an in-person appointment. We've been doing virtual type consults in our clinic for many years, long before COVID. And I think patients really appreciate it. It seems to be the way the new world is going. So recognize that patients do love it. And it is something that's coming down the pipe. So now we're going to pass it over to Brad, who's going to tell you more wisdom on his experiences.
I don't know how much more wisdom I have than you, Alan, but so I use a community-based EMR, TELUS Wolf, and my experience does mirror a lot of what Alan is saying. So we've been for about 5 years having open access to lab, DI, other reporting, essentially most of the patient's chart, and that's been active for about 5 years in my practice. We have about 5,000-ish patients that actively use and are registered to the community portal. And, I think we had a lot of similar concerns when we started. Was it going to end up with way more calls around results? And the truth is, although some patients do call more, it's balanced by some patients actually calling less because they're reassured by seeing their results in the portal. And the net balance for us has really been zero, or if anything, positive, meaning less calls about results than we had prior. We've also over time seen our patient and our patient panel overall become a little more savvy with the meaning of results and a little more empowered around self-management and taking active involvement in their own decision making. And this has actually been a big positive. Many of my patients are able to self-manage chronic conditions by having access to this information, whereas before they would have been reliant on provider contact over and over again for everything. So I see this as a big positive that's occurred slowly over time as patients have gained more confidence with their own information. We also do use asynchronous messaging, and there was a question in the chat about what that is. So in our portal, it's basically essentially an email exchange platform back and forth, but any email-like or text-like platform where you're not on together and you're exchanging information not in real time is asynchronous. And so we do a lot of follow-up around test results with messaging, and that has worked really well and actually been very efficient in terms of dealing with test results at a population or panel level for us. Can't say enough and reinforce enough what Alan said. Pre-counseling and planning with patients is really key. Taking the few extra seconds to go over why you're ordering a test and what the test results mean with the patient actually saves you a lot of effort on the back end. So, simply saying that this test is to monitor your thyroid condition. If it's elevated in this range, we'll likely be adjusting your thyroid dose. Puts patients at ease when they see that result, and then they expect the follow-up phone call or message about making a medication change. The other thing it does serve as a bit of a choosing wisely moment for us as providers, where if we're thinking about explaining why we're ordering something for a patient and we're not sure we really should order it, it might be a choice you make not to order it. So it is a bit of a choosing wisely check for us in ordering tests as well. The one thing that I will say in community practice is there may be some workflow changes that you will have to look into. And so as a team, you have to decide, do the physicians handle all questions about results? Do medical office assistants handle some? If you have the benefit of having nursing staff in your clinic, which I know most don't, but if you do, are there some results categories that nurses can follow up with? And if you are going to follow up, what kinds of messages can be done via messaging? What kind of results require a phone call? And when do you really need to see that person face to face? So the new workflow is really working out as a clinic team how you're going to handle results management in a new space where patients have access to them and may have not yet been contacted about them. Go to the next slide. So I'll just reinforce there are some limited billing codes in Alberta for both phone and messaging style appointments for following up or discussing results. We won't go into the details of this. You can find it on the fee navigator through the AMA website. But we just wanted to remind people, if you're not aware of these codes, to take some time to refresh your memories. So with that, I'm going to hand it off.
Thanks. I
Thanks,
think
Brad.
next we have Rob. Great. Thanks, Rob. Rob is an internal medicine physician at the University of, in the Edmonton area, who has also been an early Connect Care user and helped develop a lot of this. So thanks, Rob. Over to you.
Thank you very much, Heidi. Yes, it falls to me to share about the inpatient perspective. And so it's very important to recognize that both my personal records and my AHS Connect do provide patients with access to laboratory test results that arise from inpatient experiences, be those in an emergency room, in an inpatient ward, or in a critical care or surgical context. There's a little bit of a difference in that this information goes out pretty much raw and unfiltered to my personal records. There are opportunities in my AHS Connects for patients to filter out hospital results and to control what they see. The hospital-related test results also can be presented in context. So there are special reports in the portal that bring together just the hospital experience and or summarize it just prior to discharge, or link things like laboratory tests to particular care paths or care plans and messaging. So there are some differences. But for the purpose of today's discussion, let's just focus on hospital results in and of themselves, and we won't pay attention to other things such as possibly sharing notes. And if we recognize that that's our focus, we also have to recognize that we are in some uncharted territory here. Most of the literature, which is actually fairly profuse now about patient portals and their advantages, pertain to the outpatient context. The little that has been written about the inpatient context is focused on the sharing of things like consultation reports and notes rather than laboratory tests. In fact, there's only one systematic review that I could find, and it summarized only 8 half-decent quality papers that related to inpatient sharing, and again, with little to say about results. However, there's a couple of key messages that are worth sharing from the best that's known in the literature. The first is that when patients are surveyed about portal preferences, different signals emerge in the inpatient context and the outpatient context. Patients are far less likely to say that this is something they really value than they do in the outpatient context. Second, use of or desire for a portal is unevenly distributed in a hospital stay. And the systematic review calls a 5-day kind of threshold. First 5 days in hospital, things are so volatile and kind of tense and stressful. Even if patients have access to their lab results, they tend not to use them. But for the last 2 days prior to discharge, there's quite an uptick in desire for an access to that. There's also concern being expressed in the literature about offloading responsibility and anxieties associated with that for tracking laboratory results. And so there's some interesting ethics writing, which we won't go into now. So promoting portal awareness. At a very minimum, the hospital experience is a very important opportunity for promoting portal access. Yes, quite a few patients do have access now, but I find the majority of those who I admit don't. And so I've included in my admission protocol and interview a question about whether the patient and or a designated decision maker, proxy decision maker, has access to one or both of the big portals or something else. And the question that I lead with is, do you have any way with a digital tool that you're currently using for managing your personal health information? Interestingly, I'm finding that a lot of patients are reporting products on the general internet that are emerging very rapidly that I wasn't even necessarily aware of. I document as part of my admission history and physical what use, if any, they are making of portal products today. Now, in my HS Connect, you're automatically alerted with a prominent signal about whether the patient is awaiting activation, if they're actually a user, and if they're an active user, if they're using it for communication or access to notes or results. And so there the focus is more on being very clear about what the patient's expectations are if they are an active My AHS Connect user. Now, the final thing that I do, and I try to remember to document, is that I alert the patient that for what happens from the day of their admission forward, I'm taking responsibility for any discussions they wish to have about their lab results. And that's not something that we expect the family doctor to pick up on. This is my context, and things will be different in this context, and I'll take responsibility. Next slide. So what about that counseling conversation? Well, often it's pretty simple because the patient doesn't have or want to have access, and maybe it's about, well, later in the hospitalization, we're going to talk about getting you activated if you don't want it now. And as I said earlier, that conversation may be with a family member, not with the sick patient. But when I do have a conversation, the counseling emphasizes that things are different in the hospital context. So I pretty much give a blanket warning about the potential harms of hospital laboratory results. First of all, I say that a result lacks clinical meaning without knowledge of the question. And the questions that we ask in hospital are sometimes radically different from the purpose in seeking a test in a primary care setting. Second, I emphasize that it would be abnormal to be normal. You are going to have a mess of abnormal tests in hospital, and we totally expect that, and it doesn't cause us any fret or concern. What we as clinicians are focusing on is trends and triggers. And so I highlight that to the patient, and I say there's a couple of trends that we're really going to pay attention to with your community-acquired pneumonia, and there will be a trigger for when we switch from IV to oral antibiotics based on this test or two, but just some general high-level pointers. The next thing I emphasize is that there's a vast amount of data arising in the hospital environment, and that dramatically increases the probability that some of it will be misleading. There's a 5% false positive, false negative rate, which means that for every 20 tests, at least one of them is going to be misleading in one way or another. We know that, we have experience, and we don't expect our patients to develop that instinct, but we can help. And therefore, we'd like to avoid talking about every single test. What we'll focus on in our rounds is the patterns and the trends, and again, the triggers. And as we get close to discharge, what we'll do is we'll try to identify one or two laboratory tests that are going to be important to bridge to the outpatient setting for following the progress of further convalescence. So what about consent? Have I adequately informed my patient about potential harms? Well, I emphasize that what we're basically making a compact or an agreement to do is that it's my job to pay attention to the minutia, and I will communicate at the level of the pattern and the trends, and whether we are on track for the patient's objectives and their pathway, or whether the lab results are signaling that we might be off track in some way, and that I will communicate at the level of the path, not at the level of all the details. I also emphasize that the tests that we order sometimes are known only in a just-in-time fashion. They're part of protocols, and I won't be able to get a pre-permission for every single detail. The consent to be hospitalized for treatment of that pneumonia implies the little shifts in testing that we sometimes have to make. Next slide. So my general advice to inpatients is take this opportunity to get activated, and that's, in the case of my personal record, sign up. In the case of my HS Connect, at the point of admission, that's when I try and make sure that the activation code is initiated so that by the time of the discharge, the patient can leave with access not only to my personal record, but also to my HS Connect. In general, I advise my HS Connect patients to filter out the hospital results until the time is right, and it'll be sometime later in the hospital stay. And with my personal record, I generally say, you know, let's not look at all of those details. Let's have a conversation about the big picture. Next slide. So you may think that I'm suggesting that we avoid portals in the outpatient experience, in the inpatient experience, and exactly the opposite. I'm a real enthusiast. I've had a lot of good experiences, but I think that the use needs to be focused on specific use cases. And I'll give you 4 examples. The first is pretty obvious. We have patients who come in with a medical condition that stresses them, and their diabetes may get a little bit out of whack. And what I really like to do is to see how they handle it rather than I would handle it. So I put a lot of my patients on insulin self-administration, and I want them to follow their glucose and other key lab parameters that we discuss. In my patients with hyponatremia, and maybe it's polydipsia, or maybe there's other interventions that the patient has a role in, I want them to follow their sodium. So there's specific cases where it's very useful from day one of hospitalization to follow and trend. In stable patients who are on prolonged treatments and end up in hospital because of maybe parental antibiotic or other needs, maybe there's some immunosuppression issues, I really like to take the opportunity to help identify the role of tests in their disease. You know, with a SBE patient, is the outcome we're going to track CRP, something like that. And so just focusing on one or two tests and how it's part of a longer care pathway, I find that very useful. And my patients, when I come around on rounds, will say, oh, I noticed that my test improved in this way or that way. And that doesn't threaten me. I actually find that quite gratifying. Next slide. Discharge preparation. This is when I try to go a little bit more general. We do try to make sure that most of our patients leave hospital with the ability to access the portal if they want to. And I want to make sure that I use that opportunity in discharge planning to say, okay, you're on anticoagulants, it's going to be for this amount of time. These are the things that you might want to pay attention to. So let's use the next couple of days for you to get a feel for them. And what's the normal range for you? Not the general population, but what are we focused on for you? You have chronic kidney disease. What is the hemoglobin that matters for you as opposed to the general population? And then finally, there's sometimes patients who come in with situations where you would think you would stay very far away from a portal, but they really want to be very deeply engaged, such as the workup, a metastatic workup of a new malignancy. And that's where I will spend more time early in the hospital stay, talking through what our plan is, what tests will be done, what we're expecting, and how the way in which the results appear may be misleadingly alarming, and when we will talk about that. Next slide. And so in sum, I think that there are some broad cautions. I don't think that we deeply understand the implications of releasing all laboratory results real time for a patient in critical care or who's really sick in hospital. But I do think that it's an important opportunity for promoting portal use, for documenting, and for using some focused use cases to get patients ready for effective portal use when they leave hospital. And those would be the main things I would share. Thanks.
Thanks, Rob. I think at this point, we're going to pass it over to Dr. Jay Esau to provide us with a bit of an oncology perspective.
Thanks, Heidi. So from an oncology perspective, oncology has not deployed yet with Connect Care in the province. So I think that the purpose of this particular part of the talk will be to probably empathize with a lot of the concerns that many of you have about, is this going to become a problem and not a good thing? Now, you've heard that many of those who have direct experience are finding that it's not an issue. And some of you may be thinking like we do, well, maybe it's different in our field. And I'm going to just speak to you a little bit on oncology and give you actually a case example that might demonstrate where we get concerned. So for those of you that don't know, oncology covers obviously all cancer in Alberta. It includes pediatrics and adults. And adults, we divide into solid tumors and hematological cancers. Chemo, I'm a medical oncologist, is delivered throughout the province. And we work on a spoke and wheel model, where Calgary and Edmonton are kind of the hubs where the consultants will see the patients, and then care is delivered out in their community closer to their home. Next slide. So as I said, we haven't deployed, and if you were to take a survey of the oncologists, there's concern. We know that oncology, and it might be similar for your environment, is a very high stress environment. We're giving chemotherapy, and patients literally live from scan to scan. So they're waiting for those results. Is the cancer progressed? Is it stable? And the other key thing about oncology is it's very much team medicine. So we have a difficult case. We always bring it back to tumor board rounds, and multiple specialties are commenting on that case. Concern about early release data is that there might not be time for an oncologist to consult with the other groups to get an opinion. Let me give you an example. Next slide. So this is an example. So I treat brain tumor. And so this is an example of an MRI scan. And on your right, you see a white arrow pointing to a faint sort of whitish area underneath the right ventricle. And that scan was done in October. And now in December, so this is just last month, you can see that that area just underneath the right ventricle is now more prominent. And for those of you that look at brain tumor scan or look at MRI scans, that doesn't look like a tumor. But the radiologist reported it as this looks like progression of the cancer. And so somehow this patient got their result and immediately called our office demanding to see me or talk to me right away about their cancer having progressed. And I actually didn't take that call. What I did instead is I talked to the radiation oncologist who gave the radiation, who then overlaid his radiation treatment with this MRI scan and said, that area falls in the area where the patient got radiation. I was then able to talk to the radiation radiologist, who then confirmed that that could be an alternative explanation. And then I talked to the patient. And so this is an example where, you could see a patient jumping the gun because a radiologist who, no fault of their own, doesn't know where the radiation treatment was given or even that radiation was given. Next slide. So cases like this, I think, are concerning because they're ambiguous. They need consultation with different services. And I know it says better discussed over the phone, but this is actually not better discussed over the phone. This needs to be done in person. Next slide. So this experience, I think it just speaks to the fact that if there's one thing I think that you should take from today, it's this is going to be our new reality, and there's going to be a new step in how we speak to our patients, and that is we have to counsel them beforehand so that they may see a result and it may be very concerning, but they need to wait until they hear from us so that we've been able to talk to all the people that we need to come up with a logical approach. Currently, there is a 5-day delay for things like radiology and genetics and pathology. That actually may change in the future. That's uncertain, but at least there is some delay that gives us some time to speak with our other colleagues. And that's it for me.
Thanks, Jay. And last but not least, we're going to hear a CPSA perspective from Dr. Ewan Affleck. Over to you.
Thanks, Heidi. Appreciate it. So I just wanted to restate something that Rob Hayward had stated, that we don't understand the full implications of this change. This will change workflow. This will change, and he said that in the context of certainly hospital-based care, but I think that this can be applied broadly. This will change workflow, accountability for results management, follow-up, so forth and so on, potentially. So the CPSA, I've reviewed the standards. There are 3 principal standards that may be impacted by some of these workflow changes that we see: continuity of care, episodic care, transfer of care, and I'll talk in a moment about some specific examples there. But it should be understood these standards, which are written as sort of benchmarks of competence and excellence in care to promote quality of care. They're not punitive, but they are pre-existing this change, and so we need to recognize that there is what we call the test of reasonableness. That as long as the intent is to accommodate these changes in a manner that upholds quality of care, that is essential. So just next slide, please. So I've put down a few scenarios here that may occur in the context of the changes that we foresee. And some of them arise from questions that we have been asked or have been asked in the context of other discussions about the release of these results. And, do physicians still bear the responsibility for contacting patients with results? And really, this does not change. Yes, absolutely. Healthcare is relational. And it is important that those relationships continue, and certainly you can't assume that simply because the patient has a result that they can manage this somehow themselves. So that does not change at all. It is also essential that documentation of the management of any results be integral to any activity around that result. This again is an existing standard, and it needs to continue. One can see in this context when results one may be contacted in different ways. Potentially you won't be at your desk when you are discussing this with a patient. you still need to ensure that you are documenting all activity around the results in a coherent way that upholds the informational chain and content and quality of care. So handover of care. The issue here is, what happens if patients are getting results that may and you may be absent for a period of time, or not available on a weekend, or not available for some unforeseen reason. You have to ensure the only way you are accountable for results that you have ordered, and unless you ensure that you have a designated person covering, and that individual, that physician in that service has agreed to cover this, and this is agreed upon by both parties. The other issue that has been arising is time to care. And in this situation, one can foresee, if results are coming in relative real time, certainly as is promised for most results at the current time, what happens if a result comes in and you are not available over the weekend, for instance. Clearly, this is where the test of reasonableness needs to come into play. If in the current environment where we are accountable for communicating those results to patients who do not have access to them, and it can wait until Monday, that would continue. There is not the expectation in non-urgent or non-acute issues that you should be immediately available all the time. This is not designated, this is not outlined currently by way of example in our current standards, because this has never really been an issue, because the management of these results is has been under the control of physicians, and so this will need to be adjusted. And lastly, delegated results management. Certainly, as others have said, healthcare is a team-based activity, and certainly some results management can be delegated, and currently is, even before a portal, but one just needs to assure that the staff and the colleagues that you're delegating this management to are accredited and competent. I just want to stress one last point, and that is, and I think Alan said it, that this notion that it is deeply important that you address acute or pressing results, even though you may not have ordered them. So this presumption that you just forward results to whomever may have ordered them, irrespective of their acuity, you need to address things if it comes to your attention, irrespective of whether you've ordered them or not. So going forward, I just want to say that that we will be using or this notion of a test of reasonableness for adjudicating how issues are managed. And it's very important that we monitor the rollout of these new workflows, because and likely the standards will need to be amended or addressed or updated in some way, shape, or form based on what the new ecosystem ends out being in terms of quality care within the context of a portal. So that's it. Thank you very much. Heidi, back to you.
Thanks, everyone. So we do have some time for questions. We've